Hi, good afternoon, and welcome to Pituitary Network Association's webinar program. Today we have medical therapy in Cushing's disease, new targets, new hope, with Dr. Fleseriu, Maria Fleseriu. Okay. The Pituitary Network Association is a non-profit organization that relies on the support of our members and donors. We offer this webinar series to help educate patients, their families, and their healthcare providers. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Okay, now I want to read a little bit about Dr. Fleseriu. She is an associate professor of medicine and neurological surgery and director of the Northwest Pituitary Center at Oregon Health and Science Universities, Portland, Oregon, USA. She graduated summa cum laude from the University of Medicine and Pharmacy of Timisoara, Romania, and completed residency training in internal medicine and an endocrinology fellowship with a focus in pituitary disorders in Romania. Subsequently, she completed an additional internal medicine residency at Case Western Reserve University and an endocrinology fellowship at Cleveland Clinic in the U.S. Dr. Fleseriu has a long-standing clinical and research interest in the pathophysiology and treatment of pituitary and adrenal diseases and has published extensively, including several book chapters. Her clinical practice focuses on the diagnosis and treatment of pituitary and adrenal tumors and pituitary dysfunction, with a particular interest in acromegaly and Cushing's disease. As the director of the Northwest Pituitary Center at OHSU, Dr. Fleseriu champions a balanced approach to clinical management, combining the most recent advances in the field of neuroendocrinology and the aggressive pursuit of multidisciplinary research. She has been a P&A collaborator for several years, and she has authored several chapters regarding Cushing's syndrome, pituitary disorders in women, headache, and acromegaly in the P&A's Wiley-Blackwell book, Pituitary Disorders, Diagnosis and Management, and the 5th edition of the Pituitary Patient Resource Guide, both of which are available on our website at www.pituitarybooks.com. Okay, that concludes the bio section. I'm going to now switch presenters. There may be a few second delay.
Hi everybody, I'm Maria Fleseriu, and I wanted to thank the Pituitary Network Association for inviting me to talk about one of my favorite diseases, Cushing's disease. I'm going to focus today on medical therapy in Cushing's disease, new targets, new hope. I wanted to briefly show you my disclosures. And these are the disclosures for the last 24 months. Several of them were research to support OHSU, and I also had been an ad hoc consultant for Novartis, Ipsen, and Genentech, and several others are potential conflicts of interest with non-financial disclosures, being part of the Endocrine Society Clinical Guidelines Subcommittee. I have been before involved with the ACME committee and in several publications and committee trials. The objectives of the talks today will briefly touch on how to screen and confirm the diagnosis of Cushing's. We're going to talk about the goals of treatment and finally focus on discussing the advances in medical treatment and review clinical studies for newly FDA-approved medication. On a historical note, Hippocrates and ancient Romans already knew that the glands are the ones that secrete hormones. More than 2,000 years later, the French physiologist Brown Séquard show that the internal secretions are directly released into the blood. Cushing syndrome was though first suspected much later by Sir William Osler in 1899 when he wasn't sure if this was something else besides severe hypothyroidism. Cushing's disease itself was discovered by Harvey Cushing, and this is his first well-known patient, Minnie G, who presented with painful obesity, hypertrichosis, and amenorrhea, and Harvey Cushing found that this is due to a small, tiny pituitary tumor secreting ACTH. Who do we have to definitely screen for Cushing's? So we have to think about in patients with unusual features for age and atypical features for severity. These are a combination of data from Endocrine Society guidelines published in 2008 and then reanalyzed by the Europeans with European perspectives. So if we have early onset osteoporosis, hypertension diagnosed at a young age, depression resistant to drugs, for example, we have to think that something else is going on, and Cushing's is one of the possibilities. The features which are more specific to Cushing syndrome, like easy bruising, facial plethora, villaceous stria, and proximal muscle weakness. Also, decreasing growth velocity with weight gain in children should make us to think about Cushing's. Patients with specific clinical diagnosis, for example, if we found an incidental adrenal mass, we should screen the patient for Cushing's. Similarly, polycystic ovary syndrome sometimes should be a differential diagnosis with Cushing's, and in patients with osteoporosis and vertebral fracture, Cushing's should be on the list of differential diagnoses. How do we screen? As you know, Cushing's is very hard to diagnose. If the Cushing syndrome is suspected, we should consider an endocrinologist consultations, and the first thing that we have to do is to exclude the exogenous glucocorticoid exposure, meaning the patient should not have had any glucocorticoids recently, that being oral glucocorticoids or sometimes creams or intranasal or inhalers with higher dose and prolonged doses of steroids. Once we exclude the exogenous steroids, we have to perform one or more of the following tests. And we used to do 24-hour urine-free cortisol, and it's recommended to do at least 2 tests. Overnight 1 milligram dexamethasone, it's also used for screening for Cushing's. And I wanted to mention that the cutoff for normal has been decreased over time. Now is 1.8 microgram per deciliter, because this is screening. We want to make sure we are not missing the diagnosis in a patient with possible Cushing's. More recently, the late-night salivary cortisol that includes more than 2 tests, and sometimes I'm doing 4, has been shown with a very good both sensitivity and specificity between 92 and 100% to be a very good screening test for Cushing's. Of course, all these tests have caveats, and we're not going to talk about this specifically. How do we confirm the diagnosis of Cushing's? Any abnormal results from the previous screening, the patient has to undergo further confirmation of the diagnosis because of the risk of false positive. First, we have to exclude physiologic causes of hypercortisolism as pregnancy, for example. And after that, we have to perform 1 or 2 other studies. Usually, I consider repeating the abnormal study from before. I definitely add another study that hasn't been done through the initial screening. And also our group is doing dexamethasone CRH test that has been shown in several studies to be a very good test for differentiating Cushing's for pseudo-Cushing's. So why it's important to screen patients for Cushing's if we have a clinical indication, and then to confirm the diagnosis? Because Cushing's has many comorbidities, and the later the diagnosis, the patients have obvious complications from it. Most of them have decreased quality of life. They have neuropsychiatric disorders, sometimes with increased risk of cerebrovascular events and cognitive dysfunction. It has been shown, as you see here in this MRI, sometimes even brain atrophy. Also, patients have osteoporosis, growth arrest in children, as I mentioned before. A lot of patients with Cushing's have insulin-resistant diabetes. They have a lot of infections, sleep apnea, and hypertension and heart disease. I didn't mention it at the beginning because I wanted to focus on this. Hypertension and heart disease are the main complications of Cushing's, and they are the one that increase the risk of mortality. So what do we know about mortality in Cushing's disease? This is a study from Netherlands, and if you are looking, we have here on horizontal the follow-up duration over the years, and on vertical survival. And you see in yellow a line that's going down. This is the survival that's lower in Cushing's disease compared with these lines that are non-functioning tumor and acromegaly. So the patients with Cushing's have higher mortality. How about compare with a normal population? These times you see the curves are opposite because we have here the follow-up duration, but we have on this graph the mortality risk. So clearly we see that the mortality risk in Cushing's compared with normal matched population, it's much higher. The good news is, and we see here the studies from England, that same thing here, survival on horizontal follow-up years, that if the patients with Cushing's were not in remission, they had higher mortality or lower survival. The good news is if they were in remission, this has been improved. So what do we have to do? We have to clearly treat these patients with Cushing's disease as soon as we have a diagnosis. What are the goals of treatment? First, to try to control the hypercortisolemia, and this while minimizing comorbidities. We know that mortality risk is increasing with recurrences, and also sometimes we have to think also about direct tumor mass effects, especially for larger tumors, though these are much rare in Cushing's disease. We also have to think that we have to preserve the pituitary function, and fertility may be an issue depending on which type of treatment we choose. We also have to minimize collateral damage. If we're doing surgery, we have to avoid new neurological deficits. If we're doing medical treatment, we have to think about the systemic side effects. And finally, we also have to think about the cost, and more recently, we have to think about cost more and more. This is briefly a discussion about the algorithm for management, and I'm not going to go through all of it. I just wanted to show you first that once we have a clear-cut diagnosis, going screening and clear-cut confirmation of Cushing's, the main treatment is represented by transphenoidal surgery. If this is successful, we have to monitor patients for life. If this is failed, then we have several other options. One is to repeat the transphenoidal surgery, and sometimes this is successful too, or to go to medical therapy, and this is what we're going to talk about today. Definitely, bilateral adenomectomy and radiation are also used for treatment of Cushing's disease. So transphenoidal surgery in consensus statement and in clinical practice is the main treatment of choice for Cushing's disease unless the patient has clear-cut contraindication for surgery. What do we have to do after surgery? We have to do biochemical assessment as soon as we can to estimate if the patient is in remission, informed decision about the need for further therapy if the patient is not cured or in remission, such as repeat surgery or medical therapy. And we also have to have an idea of overall surgical success depending on the type of tumor. We know, for example, that if the patient has a microadenoma, if the surgery is done by an expert pituitary surgeon, and I wanted to point this out, there are huge differences between results from surgery done by an expert pituitary surgery versus surgeries done by somebody that's doing, could be an expert surgeon, but is doing fewer than 50 pituitary surgeries per year. The remission rates have been described to be between 65 and 90%, and I wanted to point out that even after remission, 5 to 10% of these patients will have recurrence at 5 years and sometimes at 10 years even more. Patients that are younger has been noted to have greater risk for recurrence. How about larger tumors? Luckily for us, larger tumors in Cushing's disease are less frequent than in non-functioning or in acromegaly, because the remission rate in these patients is much lower, as you can expect, with higher recurrence rate. And of course, also the recurrence rate is faster, and several studies show that this is 16 months versus 45 months. Surgical success is improved if we see a small tumor on the MRI. Of course, if the tumor is well-defined and non-invasive, the chances of cure with surgery are much higher. If we have a histological confirmation of ACTH-secreting tumor, means that the pathology shows that this was a Cushing's tumor. If we have low postoperative cortisol and long-lasting adrenal insufficiency, and I wanted to briefly mention about the last two, that several years ago we had more data thinking that if the patient has adrenal insufficiency after surgery, will be a very low likelihood of recurrence of the disease. This has not proven true. A lot of these patients could develop recurrences, so we have to undergo long life follow-up for all patients with Cushing's disease, even if they had adrenal insufficiency after surgery. Recurrence rate. Our initial study looked at 52 patients, a lot of macros because we're a tertiary center. Our cure rate was 82.7% overall, including the macroadenomas. But as you can see, despite a very good remission rate, the recurrence rate was clearly higher, 14% at 3.3 years, most likely due to a higher number of macroadenomas. A meta-analysis looking at 50 studies published showed a recurrence rate of 10% at 4.9 years with a 2% recurrence risk per year, and maximal risk shows to be between 1.5 but persists long term. So overall, depending on the type of tumors including in the studies, the recurrence rate have been shown to be anywhere from 2.4 to 22.2 at varying intervals. So we discussed briefly of how to screen patients for Cushing's. We discussed about confirming the diagnosis and why it's important to treat, because patients with Cushing's have higher mortality. And main treatment is transphenoidal surgery, but due to various reasons that I summarized before, a lot of patients are not in remission after surgery, and furthermore, large percentage of the patients that have been in remission will have a risk of recurrence. So clearly, we need treatment for a lot of patients after surgery. And over the last several years, it has been a lot of developments regarding medical therapy for Cushing's. And we have neuromodulators of ACTH release, including the newly approved somatostatin receptor ligand Pasireotide or Signifor. We also use Cabergoline off-label, and I'm going to briefly talk about that. We have another group that includes the adrenal steroidogenesis inhibitor, meaning they don't act at the pituitary level, but they block the cortisol secretion in the adrenals. And also, we have another group, the glucocorticoid receptor blocker, Mifepristone or Corlim, that has been approved last year for hyperglycemia in patients with Cushing syndrome. It has been FDA approved. And we're going to talk about each of these groups now separately. So we'll start with neuromodulators of ACTH release, that they act at the level of the pituitary, decreasing the ACTH. Briefly about Cabergoline, and I wanted to remind you this is not approved for Cushing's disease. We are using it mostly for prolactinomas. Sometimes we're using off-label also in Cabergoline. Also in acromegaly, and Cabergoline is the main dopamine agonist. We're also using bromocriptine, but bromocriptine has been shown not to be very helpful in Cushing's or acromegaly for that matter. Why it's important? Because it has been found that 80% of tumors that are secreting ACTH have receptors, so 80%. The problem is, if these receptors are present despite a very good result in vitro, in vivo, meaning in patients, just 60% had significant reduction in cortisol and just 40% had normalization of cortisol levels. So this is a good percentage overall, but remember we want to have each patient normalized. Several studies show that Cabergoline has also potential positive metabolic effects on blood pressure, improvement of glucose tolerance, independently of cortisol lowering effect. The doses that have been used for Cushing's are much higher than the one that we're using for prolactinomas, up to 7 milligrams per week, with a response rate, the maximum combined between prospective and a retrospective study, up to 40%. The side effects of these doses are mostly gastrointestinal with dizziness and some hypotension, and the valvular heart disease could be a potential concern at these doses, despite the fact that besides Parkinson's disease, there are not a lot of studies showing presence of valvular heart disease in patients that were treating for pituitary tumors. Here you have an example of from the retrospective study. Here we have percentage of upper limit of normal UFC, and here we have months of treatment. And if you're looking at each of these curves, there are several patients that have been normalized and then they escaped and the dose was increased and they have been controlled after that. These are the patients that have been controlled. Clearly 60% of them are not shown here because they have never been controlled. More recently, it has been discovered that the corticotroph adenomas predominantly express SST2/5, and you can see here, this is staining for somatostatin receptors in corticotroph tumors, magnified for more than 1,000. So because of that, Pasireotide, which is a multi-ligand somatostatin analog, has been studied in phase 1, phase 2, and then finally in a large phase 3 clinical trial for Cushing's disease. And as you can see here, this is a natural somatostatin that acts on the level of all somatostatin receptors. Previously, we have lanreotide and octreotide, which have been approved for acromegaly that are mainly a somatostatin receptor 2. And pasireotide is a multi-ligand, very powerful of level 5, which is seen in a lot of corticotroph adenomas. The doses that have been studied have been 600 and 900 milligram twice a day subcutaneously, and FDA approved Signifor Pasireotide in December last year for Cushing's disease. Let's briefly review some of the results of the main study. This included most patients refractory to prior treatments, though some patients have been de novo, a very large international study, and the patients have been treated with 12 months. Overall, the UFC normalization was 13% in the lower dose and 25% in the higher dose. The median percent UFC changes from baseline was about 50% for both groups. What this study observed is that it was a higher rate of normalization if the UFC was lower. So if we're looking here, you have in red 162 patients, and this is the overall. And you have here in blue the 980 patients, and in red the 600. So if we're looking, for example, of patients with mild Cushing's between 1.5 and less than 2 times upper limit of normal urinary free cortisol. If we're looking at the higher dose of 900, where we can see that half of these patients have been controlled. So overall, for mild Cushing's, potentially we can see in up to 50% of patients. What's more important is that early identification of non-responder is possible. So if we start the treatment, we're able to see if the drug works or not. The study showed that more than 90% of patients that have been uncontrolled on months 1 and 2 remain uncontrolled at month 6. And to me, this is very important from clinical point of view. If I start a drug, I want to know if the patient will respond or not as soon as possible. So if the patient is uncontrolled after 2 months, clearly I will switch to another medication, or maybe I would add another medication, though adding another medication will be also an off-label use. The phase 3 study also showed improvement in blood pressure, for example. And if you see here, I want you to take a look at the green lines that are going down over time. And this is systolic blood pressure, and here are diastolic blood pressure. And these are superimposed on the urinary free cortisol, and you can see here in purple the UFCs overall. So with a decrease in urinary free cortisol, it was also observed a decrease in both systolic and diastolic blood pressure. How about weight? The same thing, we have the weight in green, and we have the mean UFC over time in purple, and we can clearly see that throughout the duration of the study, patients had a significant decrease in weight. The mean was 6.7 kilogram over 12 months. How about tumor shrinkage? In the main studies, this was a very large study, but a lot of patients have been post-surgery. So we do not have clear-cut visible tumor on the MRI for more than half of these patients. Where the tumor was visible, it was noted tumor shrinkage. On the other hand, but this is one case, in a patient that was recently published from the study, if you're looking, these patients had never had surgery, and these are the baseline tumors. So we see here, this is a sagittal, a lateral view, and I can show you this is a tumor, this is the stalk, and it's pretty close to the optic chiasm. This is a coronal view, this is tumor, this is optic chiasm, and we can barely see there the stalk that's clearly deviated. After 6 months of treatment, the tumor got smaller, and this is visible both in the sagittal and in the coronal view. And after another 6 months, so at a year of treatment, we can see that the tumor decreased with more than 50%, and it's barely visible here. So potentially, this drug acting at the pituitary level has an effect on tumor shrinkage. How about the safety profile? 8% of patients had adrenal insufficiency during the study, which was responsive to dose reduction. To me, a drug that's inducing potentially adrenal insufficiency show that it works. That being said, patients have to clearly be counseled about the potential for adrenal insufficiency. The physicians which are using have to also be aware and responsive to dose reduction pretty quickly. And also the patients need bracelets and probably a leaflet to discuss all these potential issues for a new drug. The adverse events were largely gastrointestinal in the study, and 17% of the patients discontinued treatment due to adverse events. The safety overall was similar to other drugs that we're using for acromegaly, as lenalidomide and octreotide, with the exception of degree and severity of hyperglycemia. I wanted to mention that these patients, 73% of patients had hyperglycemia during the study, and of the baseline normal glycemic patients, 43% of them became pre-diabetic and 34% of them became diabetic. So blood glucose control, it's important, and we have to be aware of the potential mechanisms and also to treat aggressively and as soon as possible. We really don't know exactly what's the mechanism of pasireotide-related hyperglycemia in Cushing's or acromegaly, but have been studied of pasireotide-related hyperglycemia in healthy volunteer. And this suggests that the mechanism is related to decreases in insulin secretion, significantly decreased incretin response, and it does not affect insulin sensitivity. The studies in healthy volunteer also found that the most effective drugs for ameliorating pasireotide-induced hyperglycemia have been DPP-4 inhibitors and GLP-1 agonists. I wanted to clearly remind all of you that these were studies done in healthy volunteers, and we're still treating a lot of our Cushing's patients, for example, as first line with metformin, and if this is not controlling, potentially we add DPP-4 inhibitors. Which are the assessments that are recommending before and during therapy with pasireotide? So prior to therapy, we should assess fasting plasma glucose and A1C. You saw that this drug can increase and sometimes rapidly the glucose. We have to perform an EKG. We have to assess liver function and educate the patients on adrenal insufficiency symptoms. And this has to be done for all treatments for Cushing's, including transphenoidal surgery. After the therapy, we have to perform an EKG to monitor heart rate, and especially in the first week, because these drugs can induce bradycardia. We have to monitor fasting blood sugars and A1C, and we have to monitor liver function as well as adrenal insufficiency if the patient has any symptoms. Let's switch gears and talk about the other group, adrenal steroidogenesis inhibitors. And all these drugs act to block the cortisol secretion at the adrenal gland. And if you see here, and I'm not going to ask you at the end the names of all these enzymes, this is just for medical students and sometimes for us on the boards. But you can see that these drugs, for example, ketoconazole, are blocking multiple enzymes. Here in red, we have a new drug that's still in clinical trials, and I'm going to briefly discuss about it. Let's start with ketoconazole. We're using ketoconazole off-label. This has not been approved for Cushing disease, but we're using it for years and years. We usually start with 200 milligram daily and increase as tolerated up to 400 and sometimes 1200 milligram daily. We have to remember that this has multiple drug interactions. We clearly have to monitor liver function, and the ketoconazole, the Nizoral used for Candida, has a new FDA black box warning of possible liver toxicity, and we should all adapt to that. Important to remember for ketoconazole, that needs acidic gastric pH for absorption, and sometimes have been seen escapes from treatment due to the mechanism of the drug. And the main side effects, besides the liver problems, are hypogonadism in men and sometimes other gastrointestinal problems. The largest and retrospective, and I wanted to tell you that there are no prospective studies, meaning looking at the patients over time prospectively, but retrospectively, the largest study, including 38 patients, was done. It's a multi-center in France, and they looked at all their patients on ketoconazole. And when they looked back, they found out that 5 stopped within a week. The dose that has been used was between 200 and 1200, and these patients have been followed for 23 months, and 45% of these have been responders. And all have been controlled, responded within 3 months. So again, the same thing as I mentioned with Pasireotide, it's good if we know relatively quickly if the patient will respond to a therapy or not. There are no significant differences in doses, and if you can see here, this is UFC, and these are number of control patients. In the doses that have been used in patients that have been controlled, this is the normal, the gray area for normal cortisol, and the patients that have never been controlled. So this is not dose related. The exact mechanism why some patients are responders to ketoconazole and some they don't respond almost at all, it's not known. We also have a drug that's the only drug that we can use intravenous, and it's very efficacious, particularly in cases with severe Cushing's and if the patient has sepsis or other serious complications. And sometimes we're using it in patients that are very unstable to undergo surgery. The doses we're using first, it's a bolus, and then it's an infusion. In US, we have to admit the patients in ICU to be able to use this drug. This is also used off-label and has not been approved for Cushing's. The last adrenal steroidogenesis inhibitor that I'm going to talk about is the LCI 699. This was a very small study, 12 patients. This was a proof of concept. And if you are looking out of these patients, this is the mean UFC on fold over the upper limit of normal. So they had very high urine. The mean was between 4 and 5 upper limit of normal. And 11 out of 12 patients normalized by the end of the study. And throughout the study, at least once, all patients have been normal. And after stopping the drug, the urinary free cortisol went back up. So this shows that this is a very powerful drug. 4 patients had been noted to have hypokalemia. This study has not been published yet. This is the oral abstract presentation at the end of last year. We're going to talk now about the glucocorticoid receptor blocker. So I want you to point out that this is a totally different mechanism. So this drug is not going to decrease the cortisol. this drug is going to block the cortisol effect. And this is similar with what we are using for acromegaly, for example, where we use pegvisomant as a blocker of growth hormone. We're also using in other endocrine disease, for example, spironolactone, to block the aldosterone. So this mechanism has been used before, but for Cushing's, this drug has recently been approved by FDA for hyperglycemia or diabetes associated with Cushing syndrome. So in difference with Pasireotide that has been approved for Cushing's disease, this drug has been approved for all hyperglycemia and diabetes associated with Cushing syndrome, so not just Cushing's disease. It's a glucocorticoid receptor antagonist at higher doses, and also it's a potent antiprogestin drug, and this, we have to remember, this is contraindicated in pregnancy because of that. There have been over 54 case reports using this drug for Cushing syndrome, and then there have been an additional 50 patients in seismic study. Out of these, 43 of them had Cushing's disease. FDA approved in February 2012 as Korlim for hyperglycemia associated with Cushing syndrome, as I mentioned before, and the doses used are between 300 and 1200 milligram daily. We'll briefly review some of the results from phase 3 trial. So the main improvement was in diabetes, blood sugars, insulin level. I have here for you the A1C, and if you're looking, this is A1C of 7. If you're looking out of the baseline to week 16 and then week 24, was a clearly significantly statistic decrease in A1C. And the same trend was seen for insulin level and also for glucose. Also, the patients noted significant clinical improvement. The data has been recently published. Patients also had a significant decrease in weight, and if you have, this is percent change from baseline, and if you're looking clearly, the patients lost about 5.7%, and they started around 99.5 kilograms. Also, this drug induced significant decrease in waist circumference, and you have here the mean change from baseline, and we have females on the left and males on the right. And if you can see, for example, here we're 7 centimeters, and in the group of diabetes male, it was almost 12 centimeters decrease in waist circumference, and this is very important. How about safety profile? 88% experienced study-related adverse events, nausea, fatigue, and headaches. 14% withdrew due to adverse event, and this is what usually seen in the study. Hypokalemia that we expect with the mechanism of this drug was common, but in general was mild to moderate and was treated with spironolactone and potassium, sometimes with very high doses. The adrenal insufficiency was uncommonly reported as adrenal insufficiency. There have been several cases that have been treated with glucocorticoids and the drug was held due to suspicion for adrenal insufficiency, and then importantly, the Mifepristone was restarted at lower doses, and then the adrenal insufficiency did not recur. Also, the safety profile has to include the endometrial thickness, because we know that the drug has known antiprogestin activity. And it has been seen that the endometrial thickness is increasing in women, and in a study increased in 38% of the women, and earlier this year, this long-term data has been presented but not published yet. There have been 5 cases of vaginal bleeding, 2 with prolonged bleeding after stopping, and the histology showed typical changes associated with progesterone receptor modulated drugs, including thickening with glandular cystic dilatation, but this was not endometrial hyperplasia. What should we do if we're using this drug? Before starting Mifepristone, we have to evaluate for hypokalemia. If the patient has low potassium, we have to replace it. Sometimes we're starting spironolactone if needing to control potential hypokalemia before even starting the drug, knowing that this drug can potentially worsen it. We also have to look at the list for concomitant medication, because this drug has several drug-drug interactions, which could potentially increase or decrease the availability of the drug. We also have to review the menstrual status, advise the patient, the women, to watch for any vaginal bleeding after starting the drug, and sometimes they require biopsy if they continue to bleed. and also to review the patient clinical signs of adrenal insufficiency. This is important, as I mentioned before, for all types of therapy. For this drug, it's even more important because checking cortisol is not reliable. Once we start the drug, usually we start at a lower dose of 300 milligrams daily with food, and further titration is done as needed based on clinical efficacy and tolerability. We have to recheck a potassium in 1 to 2 weeks. We also have to discuss with patients and the local provider the dose of dexamethasone usually needed to treat adrenal insufficiency, because we're using a little bit higher doses than usually, sometimes 2 milligrams every 6 to 12 hours. And as a reminder, because this is blocking the cortisol receptor, the glucocorticoid receptor, cortisol is not a marker of efficacy and will be elevated. So it's no need to monitor it in order to see if the drug works, and it cannot be used as a clinic or biochemical sign for adrenal insufficiency either. So everything has to be based on clinical efficacy and tolerability. So I presented to you the data that we had for 3 groups of drugs: ACTH neuromodulators, adrenal steroidogenase inhibitors, and glucocorticoid receptor blockers. I also wanted to talk to you in the end about possible combination therapy. So more recently, because none of these drugs are perfect, as you saw, lower doses of combination of these drugs have been used, and I'm going to show you the data for 2 small studies that are very promising. For example, this was a study that included 18 patients, and if you're looking here, we have the 24 urinary free cortisol, and this was the duration of the treatment. So all the patients have been started on Pasireotide. 5 of them responded to normal. The patients that have not responded, Cabergoline was added, and the patient that did not respond to combination to Pasireotide and Cabergoline had in addition also Ketoconazole. And as you can see, almost everybody, 88% actually, achieved normal urinary free cortisol, and the mean of all this was a little bit over the upper limit of normal. So potentially, clearly, we need larger studies with more data regarding efficacy, possible escape, safety, tolerability. But this was a very exciting study showing that using smaller doses of each of these drugs, we can control the patients, and possible they will also have synergistic effects, meaning if we're using them together, they actually work better than the addition of each of them separately. Another very small study, this type was all of them adrenal steroidogenesis inhibitors, so drugs that work at the adrenal level. There were 11 patients, very sick patients that could not even undergo bilateral adenomectomy due to the severity of their disease. Just 4 of these patients had Cushing disease. This study was done in France, and they have been started, all of them in the same time, with very high doses of mitoten, methylrapone, and ketoconazole. And as you can see here, this is patient 1, 2, 3. This is where they started, and this is where they ended after treatment. And you can clearly see that a lot of patients actually normalized, and most of them noticed a significant decrease in urinary free cortisol. The side effects were most gastrointestinal. Also, a rise in cholesterol and gamma-GT were observed. What else do we have available as medical therapy that sometimes we have to use in very aggressive corticotroph tumors? And as I mentioned earlier, most of the Cushing's tumors are very small microadenomas. Some of them are, though, macroadenomas, and a small proportion of these are very large, aggressive, and recurrent ACTH-secreting tumors. And sometimes these tumors also become cancer, though this is extremely rare. Temodar, it's used off-label for pituitary tumors, but has been approved, it's a chemotherapy that has been approved for glioblastoma. And recently, us and some others showed that Temodar can be also used in corticotroph tumors that are very aggressive and sometimes with good results. There are up to now about 12 corticotroph adenomas treated, with 8 carcinomas treated alone or in combination with various treatment doses and regimens. And the most commonly used regimen is between 150 and 200 milligram per meter square per day for 5 days each month. And I have to tell you, for a chemotherapy, we're not oncologists, but this is a relatively well-tolerated chemotherapy. The follow-up was available for 15 of these cases, averaging 6 months, with positive responses noted for up to 34 months. I wanted to point out that all of these have been retrospective studies or case reports, and sometimes, if it's not a prospective studies, the cases that had been more successfully treated have a tendency of being published more. And as an example, look at this case. This was our case, that the patient, you can see here, this was a very large tumor. This is sagittal, this is coronal view, and this patient had undergone, before treating with Temodar, 5 surgeries and 2 radiations. After 10 weeks of using this drug, you can clearly see a significant shrinkage of the tumor, and this was persistent over a year. In conclusion, prompt and appropriate intervention can restore mortality rates to those of the general population, and patients should be followed for as long as possible to monitor remission. Unfortunately, the management of persistent or recurrent Cushing's disease remains a challenge, and I hope I showed you, reviewing all this data from studies. Combination treatments have emerged, but to end on a good note, medical therapy plays a critical role in the control of hypercortisolemia and associated symptoms, but better drugs are still needed. Thank you, and I left now 10 minutes for questions, and thank you all for listening.
Hi, Dr. Fleseriu. It's Jackie. I'm back with you. Okay, we do have a couple of questions here for you. Let's see, the first one. I have been on Ketoconazole for 3 years now, and I have liver damage. My endo is taking me off of it and putting me on Korlym because I also have type 2 diabetes, and it's been out of control. Does anyone know about Korlym and what the side effects are?
So, this is a very interesting question. That depends, and what I would recommend for the patient is to clearly discuss all the options with her endocrinologist. What I can talk about in general is we did observe in some patients increase in transaminase, for example, without liver damage that got better over time. If she was on treatment for 3 years and she already, the patient has liver damage per se, definitely I would not continue Ketoconazole. Korlym has been approved, or Mifepristone, the generic name, has been approved for Cushing's syndrome, especially in patients that have hyperglycemia or diabetes. So if the diabetes is uncontrolled, definitely Korlym would be on my list for the next drug to start. What we should do, as I mentioned earlier, this is a very interesting drug and has to be closely watched. It has been shown to significantly improve diabetes, for example, so it's possible that the patient will notice improvement in diabetes very soon after starting the drug. But especially if it's a woman, we have to make sure that the patient does not get pregnant. We have to look at the potassium in detail, the potassium to be clearly, completely normal after before starting the drug, and then recheck the potassium at least 1 to 2 weeks after starting the drug. And then also, if the patient is on treatment for diabetes, the drugs for diabetes have to be sometimes adjusted. In the studies, some of these patients were completely taken off insulin, in my experience, so need very, very close follow-up. Of course, there are side effects with each drug, but probably for this particular patient, unless the patient has a large tumor with uncontrolled diabetes, this would be, and if no history of vaginal bleeding and no interest for pregnancy, this would probably be my next drug on the list. If the A1C is, for example, 10 or 11. With uncontrolled diabetes, this would be probably my choice.
Okay, great. Thank you. Okay, the next question is, Which test will help a patient determine what tumor receptors should be targeted in their tumors for the most successful drug therapy?
Thank you for your question. This is a very interesting question that all of us are asking. Right now, we have no markers to know which drug will work. As you saw, there are some patients that have corticotroph tumor receptors and they don't respond to treatment. The same thing for Cabergoline. So we don't have any data for Cushing's to say if you have this receptor, this is the drug to do. So that's why I mentioned what we're looking at is we're looking at the drugs that we can figure out pretty quickly if it's going to work or not. So it's a try and error, unfortunately, and I would definitely love to have a marker and say this patient this tumor has this receptor, so this would be the first treatment and the way to go.
Okay, thank you. The next question is, was Mifepristone formerly called RU-486 the abortion drug?
Yes. So this is the same drug, but they're a little bit different doses, and was studied in 6 months and then with extension study for Cushing. So all the patients that I presented have been patients with Cushing syndrome, large majority with Cushing disease, but yes, it's the same formulation.
Okay, and a follow-up to that one, does that drug block progesterone?
Yes, so this is a powerful drug with anti-progestin activity, so that's why it's contraindicating in pregnancy. That's why we should watch for endometrial thickening if it's a woman, if the patient has vaginal bleeding, we stop the drug, and sometimes we recommend even biopsy. It does not appear that this drug induces endometrial hyperplasia. There are, at least for now, what we have, it's specific changes related to all the drugs that are modulator for progesterone activity, and these are called PAEC, meaning specific changes and not hyperplasia per se, but it's inducing endometrial thickening. So doing an ultrasound that we did in the study, for example, these patients had endometrial thickening.
Okay. Right, that makes sense. Okay, have studies been done on how the combination therapy affects the liver?
So there are no studies for combination yet. The smaller one that I showed you, especially the second one, most of the patients noted increasing in liver enzymes. The issue is these patients were very sick. Some of them were in sepsis, where you would have noted anyway increases in liver enzymes. But surprisingly, we knew that all these drugs act through the liver, so I was actually pleasantly surprised by the result that it wasn't liver failure and it was just some increase in enzymes. That being said, these were totally different cases. I would not use a combination of 3 adrenal steroidogenesis inhibitors as one of the last slides I showed in somebody with Cushing's disease that's not very, very sick and could not undergo bilateral adenomectomy, for example, or anything else. So we need way more long-term studies in a large number of patients to actually declare the safety of these combinations therapy. That's why all of them are off-label, and before starting any type of combination, I discuss with the patient, this is not approved. We can try if everything else that's approved fails.
Okay. Okay, the next question is, are Pasireotide and Cabergoline appropriate for patients who have undergone bilateral adrenalectomy but still increasing ACTH levels?
So that's a very interesting question, and I think the patient is talking about corticotroph tumor progression, what we used to call before Nelson syndrome. There are no drugs approved for Nelson syndrome. That being said, Cabergoline has been used in the past. Temodar has also been used recently in several cases, and I'm aware of 2 cases, one recently published in GCM, where Pasireotide had significant effect on the tumor that was after bilateral ectomy, so exactly the question, and also decrease in ACTH. So potentially, I can tell you, we have no prospective studies how many patients will respond, and again, there are no clear-cut markers, but definitely from physiologic point of view, it makes sense that will act on decreasing the ACTH, and then there have been few cases reported where it has been beneficial.
Okay. Okay, great. Next question is, why aren't medications used before TSS if no tumor is imaged, given negative cognitive side effects of TSS?
I'm not sure I can understand the question. So negative cognitive effects on the surgery itself. So can you ask who, to elaborate more on the question, and we can move on the next question before?
Okay. Yes, I can. Okay, the next one is...
Or I can answer that question directly by email, but I need more clarification. I'm sorry.
Okay. Okay, well, we'll follow up with email. The next one is, the triple combination treatments showed a reduction to near normal of UFC, but AEs were not noted. Several of these drugs used in the triple threat therapy have severe permanent AEs, including diabetes. Other than low potassium and being or risk of getting pregnant, it looks like the cortisol receptor blocking drug has the least amount of risk of AEs. Question.
So it's very hard to compare two drugs that have different mechanisms. So for a patient that has severe diabetes, this would be my first choice. For example, if the patient has a larger tumor, though, Pasireotide would make more sense because it acts at the level of the tumor. The same thing if the patient has severe hypokalemia and then develop worsening hypertension after starting the drug, and hypokalemia cannot be controlled. Or if it's a woman with vaginal bleeding, then we cannot continue the drug. But clearly, Mifepristone is a very good drug for selected patients. If they have diabetes or hyperglycemia, if they have small tumors, if they don't have any history of vaginal bleeding, it has to be monitored very well, but that's not an issue. Okay.
Okay, the next question. I have Cushing's disease, 2 failed transphenoidal surgeries, and am currently pan-hypopituitary. I have taken Ketoconazole 400 to 800 milligrams daily for a year, and with some weight loss and relief of symptoms, but cannot tolerate the AI and GI side effects, even with supplemental hydrocortisone taken in the AM. I have daytime fatigue, and that is only remedied by taking 2 doses of Ritalin per day. I am tired of this low quality of life and don't see any other option than bilateral adrenalectomy based on the negative side effects of the other medical therapies. I can't go on much longer as a woman, a wife, and a mother. Can you share your thoughts about this route?
So the question relates more, I can comment directly on the particular specifics of this patient, but what we know about bilateral adrenalectomy is a permanent treatment. So I have sent several patients to bilateral adrenalectomy if they failed medical therapy. So this has to be the decision of the patient and her physician. If we consider now in a patient that's pan-hypopit and was tried just on Ketoconazole and none of the other drugs, that this is failed medical therapy. Bilateral adrenalectomy has been shown to improve the quality of life in some patients. But keep in mind, we're changing a disease, Cushing's, indeed more severe, with another disease, permanent adrenal insufficiency. So I'm not sure, for example, that the fatigue would be significantly improved. Patients sometimes require very high doses of hydrocortisone. Also, they will require Florinef. So it's a method of treatment that it's used in selected cases with good results, but it's permanent. So this is a decision that we can go back. That has to be taken, but last results, everything else is failed after several discussions.
Okay. Can you provide information for patients with uncontrolled and or failed Cushing's regarding enrolling in clinical trials or studies?
So what I would suggest right now is for the patients to go on clinicaltrials.gov, and as far as I know in US for treatment, I'm not sure how many they are active right now, but it's possible that several clinical trials will open relatively soon from what appears on clinicaltrials.gov, but I cannot comment on any other information for now.
Yeah, okay. Okay, looks like I have time for maybe one more question. Let's see. If you have had low progesterone and already have uterine thickening, would it be correct to say that Mifepristone is not recommended?
I'm not sure we have enough data to say that. Definitely, I would be more worried and I would watch this patient. And if the patient already has thickening, I would probably recommend a biopsy to know exactly what's going on even before starting the treatment. But I don't think this is a completely contraindication unless the biopsy shows something. But definitely has to be checked before starting the treatment.
Okay, it looks like we're out of time. I want to thank you, Dr. Fleseriu, for doing this webinar. Very informative, very good. And this will conclude our webinar presentation. If we did not get a chance to answer your question, we will be answering them via email. The PNA wishes to thank you for participating in our webinar. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you.
Okay. Thanks a lot.
Thank you.